The learning objectives for this morning are to review the CRRT modalities, understand the rationale behind recommendations for CRRT dosing in the treatment of acute kidney injury, and to learn about some of the practical considerations related to the prescription and dose delivery. So reviewing the modalities. So CRRT represents a continuum and a spectrum of therapies from slow continuous ultrafiltration to CVVH, or continuous veno-venous hemofiltration, which uses only convection, to CVVHD, continuous veno-venous hemodialysis, which uses only diffusion, and then a hybrid therapy of continuous veno-venous hemodiafiltration. The latter three that are using some form of dialytic or convective clearance generally have the same rate of small solute removal. Again, with scuff, the mechanism of clearance, which is actually quite low, is ultrafiltration. CVVH uses convection. CVVHD uses diffusion. And you can be a convector, a diffuser, or you can put them both together and become a confuser and do CVVHDF. The treatment times are all continuous, and blood flow rates need to be matched to the patient's hemodynamic status as well as their body size. It's important to remember that the clearance in continuous renal replacement therapy is mostly related to the effluent volume or the dialysis fluid rate. Of course, if a patient has a blood flow rate of 0 mils per minute, there will be no clearance. But unlike conventional hemodialysis, it is the effluent rate that is the primary factor for CRRT clearance. If we look at this schematically, slow continuous ultrafiltration just removes fluid, plasma water, and while there is some amount of clearance, it is only the clearance of the molecules that are in the effluent bag. When we add replacement fluid, either pre or post filter, we generate a convective clearance that is equivalent to the clearance of replacement fluid, and that fluid is mil for mil, minute for minute, removed at the same rate as the fluid is replaced. In continuous veno-venous hemodialysis, again, we have countercurrent dialysis flow as well as the addition of effluent volume from ultrafiltration. And then if we use both, we can take advantage of both modalities. The effluent composition in scuff, again, is just the patient net ultrafiltrate. The effluent composition in continuous veno-venous hemofiltration is the replacement fluid plus the patient net ultrafiltrate. In dialysate with countercurrent dialysis fluid, the effluent composition is dialysate plus the patient net ultrafiltrate. And again, a combination of CVVH-DF uses both replacement fluid and dialysis fluid. So the composition is the sum of the dialysate plus the replacement fluid rate plus the patient net ultrafiltrate. Now, why would you use different modalities? In convective clearance, larger molecules are removed more efficiently than with dialysis. In solely a diffusive mode, the clearance is based on the Brownian motion of the molecule, with larger molecules moving slower, so the chance of them moving through the semipermeable membrane is lower, whereas in continuous veno-venous hemofiltration, fluid is pushed through and solute drag will drag those larger molecules at a more efficient rate than just continuous veno-venous hemodialysis. Again, with small solute clearance, the clearances are generally the same across all three of the CRRT modalities that use some form of replacement fluid or dialysis fluid. So how do we think about dosing, and what is the rationale for dosing CRRT in the treatment and support of patients with acute kidney injury? Well, dose adequacy was taken from the concept from intermittent hemodialysis to try to understand what is the minimum amount of a dose that is needed for clearance to prevent a negative outcome. That is not the same as optimal therapy, which I don't know that we completely understand, but philosophically, optimal dialysis is a dose above which we don't see any improvement in a positive benefit. We know that renal replacement therapy can be used to treat life-threatening complications of AKI that are unresponsive to other interventions, such as metabolic acidosis, severe electrolyte abnormalities, pulmonary edema, or uremic symptoms. There has been targets for minimum dose, and these have been established for chronic renal replacement therapy. However, as renal replacement therapy needs of the acutely unwell patient differs from those of ESRD patients, the same dosing paradigms may not apply. So if we look at this graph, which on the x-axis is looking at the equilibrated KT over V for each dialysis treatment and an intermittent hemo treatment, and then the weekly standardized KT over V, which is on the y-axis, we can see that depending in the intermittent therapy, depending on the number of days of the week, as you do more therapies during the week, the standard KT over V will increase. Continuous clearance improves in a mostly linear fashion because we're doing this 24 hours a day, or we're supposed to be doing this 24 hours a day, but as Dr. Pilevsky will tell you in the next talk, there are many challenges to actually delivering that dose. But CRRT over a week has the potential to provide significantly more clearance than intermittent hemodialysis. If we look at a standard KT over V comparison, which attempts to normalize the weekly dose clearance for a particular patient, irrespective of the modality, if we look at CRRT with 1,538 sessions and 244 critically ill patients with a minimum of 48 hours on CRRT and compare that weekly standard clearance to IHD of 610 sessions and 254 critically ill patients, you can actually see that irrespective of the CRRT modality that's chosen, CVVH, CVVHD, or CVVHDF, a greater standardized KT over V can be achieved, at least in this study by Clark et al. And again, here's IHD at 7 times per week. So even doing daily intermittent hemodialysis may not afford the same clearance over a week that CRRT does. And if we look at intermittent hemodialysis 3 times a week, which is what is standard of care for patients on maintenance dialysis, you can see that we don't provide nearly what continuous renal replacement therapy can. So how do we calculate this clinically? In the trials that I'll discuss and that you'll hear about later, the delivered dose is considered to be equivalent to the total effluent volume, expressed as a weight-adjusted hourly effluent rate. This estimates, again, the small solute clearance, such as urea. So these calculations, for CVVH, the effluent rate is the rate of replacement fluid in mils per hour, plus the net ultrafiltrate in mils per hour, whereas CVVHDF combines the effluent rate in mils, the replacement fluid rate in mils per hour, the dialysis fluid rate in mils per hour, and the net ultrafiltrate rate. So for example, if we're providing CVVHDF to this patient, the CRRT dose is dosed in mils per kilo per hour. You can see the sum of the dialysis fluid, replacement fluid, and patient net ultrafiltration divided by the patient's weight. So if we provide 100 mils per hour of dialysis fluid, 100 mils per hour of replacement fluid, and 200 mils per hour of net UF for the patient, that equals 2,200 mils per hour. And if the patient is the average 70 kilo patient, that leads to a dose of dialysis of 31.4 mils per kilo per hour. In the some additional aspects of CRRT dose to think about is that the effluent is generally 100% saturated with low molecular weight solutes. In chronic or intermittent hemodialysis, it's the blood flow rate that generally determines the clearance, because the blood flow rate is in mils per minute and significantly greater than the dialysis fluid rate, generally prescribed at 1.5 to 2 times the blood flow rate. However, in CRRT, that does not occur. The blood flow rate is significantly higher than the effluent rate, and therefore there is near saturation. So again, if you wanted to think about this for a particular patient at, say, 35 mils per minute, this is like moderate CKD, and so we have to think about dosing medications accordingly, and I'll talk about that near the end of the presentation. So what are the dose requirements of AKI in patients who are treated with CRRT? Is there evidence for a minimum delivered dose? Well, the KDIGO recommendation stated that a delivered effluent volume of 20 to 25 mils per kilo per hour should be prescribed or delivered in patients who have acute kidney injury. And the recommendation states, and Paul will get into this later, that a higher dose should be prescribed in order to deliver this 20 to 25 mils per kilo per hour due to downtime, changing of bags, access issues, etc. So an overview of the 3 most famous dose trials, those by Dr. Ronco in 2000, the NIH VA ATN trial that was spearheaded by Dr. Pilevsky, and the renal trial that was spearheaded by Ronaldo Bellomo, we get a sense of what the minimum dose should be. Dr. Ronco's study was a single-center randomized controlled trial evaluating the dose effect of CRRT on outcome, and this is where the concept of CRRT dose was first introduced in a randomized way. The ATN trial was the first multi-center randomized controlled trial evaluating the renal replacement therapy dose effect on outcome, and the renal trial came on the heels of the NIH VA ATN trial. In Dr. Ronco's trial, 425 patients were randomized to 3 doses, 20 mils per kilo per hour, 35 mils per kilo per hour, and 45 mils per kilo per hour. And the primary endpoint was 60-day mortality. And what you can see here, and what was provided significant hope for us in this field, is that patients in the higher dose group of 45 or 35 mils per kilo per hour demonstrated improved survival compared to patients who received 20 mils per kilo per hour. And in patients who had sepsis, patients who received 45 mils per kilo per hour had improved outcomes compared to the other 2 groups. Now, this was a single-center study in 2000, and so while this demonstrated significant promise, it needed to be validated in large randomized multi-center trials. So the VA NIH ATN study, again, that Dr. Pilevsky spearheaded, looked at intensive therapy versus less intensive therapy. And some people confuse this as a comparison between intermittent hemodialysis and CRRT. That is not what this study is looking at. Based on how ill the patient was, they would receive intermittent hemodialysis, with more ill patients then transitioning to CRRT, and the patients could switch back and forth between those modalities depending on their cardiovascular SOFA score. They did not switch, however, between intensity. So the patients who received the less intensive strategy received intermittent hemodialysis for 3 times a week with a KT over V that was measured at 1.2, and patients who received CVVH as they got sicker received 20 mils per kilo per hour or SLED. Patients who were randomized to the intensive arm received 6 times weekly intermittent hemodialysis, and those who became more unstable received 35 mils per kilo per hour. The primary outcome was death from any cause by day 60, and the secondary endpoints included in-hospital death and recovery of kidney function. And what you can see here at the 60-day mark is there was absolutely no difference in patient outcome for patients who received the less intensive versus the intensive strategy. And Dr. Pilevsky and his colleagues performed various sub-analyses, subgroup analyses to determine if in any way for any patient population the intensive therapy group fared any better. And in no area did these patients who received the intensive group fare any better. Again, looking at RT intensity and clinical outcomes, there seemed to be no difference between the intensive strategy and the less intensive strategy, and this was an incredibly well-powered study, and none of the assessments in terms of renal recovery, being off dialysis, hospital-free days, or ICU-free days, demonstrated any benefit. So again, no significant difference was reported between the groups in terms of renal recovery, ICU length of stay, or hospital stay, or the primary outcome. So this was, I think, a little bit of a depressing result, but it is what it is, because we were certainly hopeful that we would demonstrate improved outcomes. The renal study just looked at CVV-HDF out of New Zealand and Australia and New Zealand, comparing higher intensity, lower intensity CRRT. And the comparison here was a little different than ATN. Lower intensity CRRT was 25 mils per kilo per hour, and the higher intensity group was at 40 mils per kilo per hour. And the primary outcome here was death from any cause within 90 days after randomization, and there were a number of secondary endpoints as well. Similar to the ATN study, there was no difference with respect to mortality and RT intensity. So patients who received the higher intensity CRT did not have better survival. The renal study also looked at a number of secondary endpoints, as I've mentioned, and again, mortality at 90 days, and all the pre-specified subgroup assessments demonstrated no difference between those who received intensive CRT versus less intensive CRT. If we look at long-term outcomes as well, there was no difference between the groups. So if we compare these two studies, what we can say is at least up to a level of 40 mils per kilo per hour, and certainly not below a level of 20 mils per kilo per hour, can we say that there is any difference in mortality for patients receiving CRRT. And again, so no reduction in all-cause mortality. So in terms of dose intensity, KDIGO recommends delivering an effluent volume of 20 to 25 mils per kilo per hour, and those two numbers are picked because of the ATN lower limit and the renal lower limit. This is based on the evidence from these two studies, and they reinforce the need to better understand the effects of RT intensity in the complex high-risk patient population. And the best methods to optimize RT dose have yet to be identified. What is important to say is that we have not evaluated RT doses below 20, and I don't think anyone ever will, but this should not be inferred to suggest that dose doesn't matter. So what about in the final couple of slides, some other considerations beyond small solute or urea clearance? When prescribing renal replacement therapy, aspects of the medical management other than small solute clearance should be considered, including volume control, since positive fluid balance may be an independent risk factor for mortality in AKI patients. And so the goal is to provide RT to achieve the goals of electrolyte, acid-base, solute, and fluid balance that will meet the patient's needs. There are other things that are removed. There are not membranes that leave only the small solutes you'd like to stay in the patient's body behind, and only take out the ones you'd like to get rid of. So we have to think about phosphate control, and with the relatively high doses of CRRT we're using now, many patients do in fact become hypophosphatemic. We have to think about the drugs that are not highly protein bound that we may be removing, including antimicrobials, because sepsis is the #1 cause of acute kidney injury in the critically ill, and the nutrients that we are removing. In addition, fluid balance is a key factor if affected by CRRT, and we cannot disentangle solute clearance and fluid balance. Drug dosing in acute kidney injury has received a lot of attention recently, and especially in those receiving renal replacement therapy. It depends on the interplay between the drug, patient, and RRT factors during critical illness. Unlike intermittent hemodialysis, CRRT provides relatively constant clearance that's predictable, and we need to think about different CRRT-specific factors that can affect drug removal, including filter composition and the dialysis dose. We should be thinking about drug dosing issues with antibiotics, anticoagulants, and the whole list of medications you can see here. And I refer you to this article by Tom Nolan and the Kidney Health Initiative, which talks about the challenges of understanding how to dose medications in patients receiving continuous renal replacement therapy, because we do not have an expansive list of pharmacokinetic data to assist us in this endeavor. So in conclusion, consistent data from the ATN and renal trials show no benefit of increasing doses above 20 to 25 mils per kilo per hour. Dr. Polevsky will show you that delivered doses in AKI may often be lower than prescribed doses, and so you should measure this. In order to achieve an adequate delivered dose, therefore, it may be necessary to prescribe in the range of 25 to 30 mils per kilo per hour to minimize interruptions and to minimize interruptions in CRRT. But this dose should be individualized to meet each patient's needs, taking into account factors other than small solute clearance. Urea clearance is not the holy grail. It's not the only thing we should be paying attention to, but it is the first thing we should pay attention to. I appreciate the opportunity to speak about this, and thank you for your attention.